Welcome back, everybody. Let's get right into it. Our next speaker is Dr. Jonathan Miller. He is a general pediatrician and hospitalist at Nemours Children's Health, Delaware Valley. He is also the Interim Chief Value Officer and Medical Director for Value-Based Care at Nemours Children's Health, and a Clinical Associate Professor of Pediatrics at Sidney Kimmel Medical College at Thomas Jefferson University. Dr. Miller received the General Pediatrics Faculty Academic Award for Research from the General Academics Pediatrics Division of Nemours A.I. DuPont Hospital for Children in 2021, and was one of Delaware Today's top doctors in 2019. He serves on the Delaware Public Health Ethics Advisory Group to the Delaware Division of Public Health, and was appointed the chair of the Childhood Lead Poisoning Advisory Committee by Governor John Carney. Dr. Miller attended medical school at the Johns Hopkins University School of Medicine in Baltimore, Maryland. He completed his pediatrics residency at Yale New Haven Hospital and a fellowship in clinical medical ethics at McLean Center, University of Chicago. Dr. Miller, take it away.
Thank you very much. Let me share my presentation. I appreciate the intro. All right. Can you see it full screen, Kate?
Yep, looks perfect.
Okay. All right, awesome. So thank you all for letting me come speak with you today. My name is Jonathan Miller. I'm a general pediatrician and an ethicist, and I've spent a lot of my time prior to the pandemic thinking about and talking about vaccine hesitancy. And so I was asked to give this talk today, and I thought about whether this should be just like a COVID vaccine hesitancy talk or sort of broader than that. But really, on reflecting on it, the pandemic has impacted everything that we do, right? And it has clearly impacted the way people approach immunizations in general and confidence and hesitancy in immunizations in general, not just as it pertains to the COVID vaccine. And so I'm going to talk about everything today, but I will focus a little bit in on COVID, particularly if we have time. I can talk about this all day. So I have nothing to disclose other than that I am strongly sort of evidence-based in my approach to medicine, and therefore I'm pretty pro immunization. So I'm going to give three quick case vignettes to sort of, and again, take a step back. This talk is going to be really from the perspective of a pediatrician. I'll touch a little bit on sort of adult vaccine and hesitancy, really as it pertains to COVID, but for the most part, this talk is really about vaccine hesitancy and confidence as it pertains to the pediatric world. So three quick case vignettes that I think highlight the kind of stuff we're up against as pediatricians. First is the 1-year-old who is completely unvaccinated, and the parents will sort of throw any rationale at you. It's religious, they don't trust big pharma, they're worried about autism, yada yada, all of it. And so, the question that I want to ask and hopefully provide some answers to today is sort of, how do you manage that? How do you manage that as the provider? How do you manage that as a medical system? How should we be managing that as a society? Case 2, and this is a lot more common, is the 11-year-old who comes in for a sports physical and is due for the typical 11-year-old vaccines like their tetanus shot and their meningitis and HPV, and also flu, because we're in the middle of flu season, and the family says yes to the Tdap and Menactra, but not to the flu and the HPV because those aren't required for school. How do you handle that? And then the last one is the new case, right? This is what we're seeing like this week, right? And this is the 7-year-old who comes to your office for some other problem. You manage that other problem, and then you dig in and decide to talk to them about the COVID vaccine. And the parents say, yeah, we've gotten the COVID vaccine, but we're not ready to give it to our daughter yet. She's 7. We know that the FDA has approved this, but we don't think it's sort of been studied long enough. We're worried about long-term complications. We're worried about fertility. We're worried about heart inflammation. And so sort of how are we going to handle that? So today we're gonna briefly touch on sort of what is recommended, what is known about true, real side effects. We're going to take a journey through the history of vaccine hesitancy, and then talk about how COVID has impacted that. And then finally, you know, I'd like to talk a little bit about what we can do about it. If we have any time at the end, I'll talk a little bit about some research that we're doing here in Delaware on COVID vaccine hesitancy. So every year, the Advisory Committee on Immunization Practices of the CDC, in partnership with the AAP and others, puts out a recommendation for routine immunization. This is the recommendations for children. There's a catch-up table. I'm not going to get into it. There's a specific sort of medical indication disease state table that tells you, for instance, what to do for someone who has HIV. This year, they added a little box that said, you know, if the FDA approves under emergency use COVID vaccine for a pediatric age group, we're recommending that too. And then there's also adult schedules, both for by age group and also by disease state. And vaccines that are recommended routinely in the United States work really, really well for the large part, right? So most are greater than 90% efficacy. Polio, measles, varicella approach 99% in their efficacy. Hepatitis B is over 90%. There's a whole group of us that are non-responders to that, but that's still a small percentage. But it's important to know that vaccines are not perfect, right? There are a few vaccines that just aren't at that standard. So for instance, the DTP used to be really good, but in the 80s, after a lot of lawsuits against pharmaceutical companies led to, and we'll get into this a little bit later, but led to some problems because the DTP was really immunogenic, but also caused a lot of side effects. It was reformulated with an acellular pertussis formulation, and it's much better tolerated, but it's also not as immunogenic, and so we see pertussis outbreaks occasionally. Mumps, less than 90% effective. We see mumps outbreaks occasionally. And then flu, I think, as we all know, really varies year to year. But efficacy usually is somewhere between 30 and 60%, depending on the strain in the vaccine that you're talking about. Side effects. So all the vaccines that I've already sort of shown you on the screen are very safe, okay? They can have local reactions, pain, bleeding, bruising, a lump. Sometimes kids will get a little lump in their thigh. You can get systemic, you know, feel fluish, right? Achy, headaches. And teenagers tend to try to pass out on you, so we often have them hang out for a few minutes before they leave the office. The live virus vaccines, measles and varicella, can cause a rash. There are known real serious side effects of vaccines, and it's really important for us as the healthcare establishment to have a good handle on what those are, okay? So anaphylaxis, for most vaccines, about 1 in a million for an allergic reaction. Febrile seizures, anything that can cause fevers in children, including immunizations, has the potential, albeit rarely, to cause seizures with those fevers. Those tend not to be serious, but they're scary. And then I put a list here of the other known serious side effects. The first two are DTP, not DTAP, so those are things that we don't really see anymore. Oral polio vaccine, which we do not use in the United States, but is used in some countries around the world, is occasionally associated with vaccine-type polio. Rotavirus, very rarely, but can cause intussusception. MMR can cause low platelets. Varicella vaccine can actually cause shingles. It's pretty mild when it happens, but it happens. In the history of flu vaccine, it has had some years where it was associated with Guillain-Barré syndrome. That's not typically the case in most seasons. And then now we know COVID vaccine seems to be associated with sort of a mild and transient and rare myocarditis. And what you won't find here is the things like autism or severe long-term problems, right? There's no serious long-term complications on this list, right? Other than the oral polio, again, not one we use here. Okay. couple specific vaccines that if you're going to have discussions about vaccine hesitancy and confidence, you really need to have a mastery of these vaccines. MMR is one of them, because the history of vaccine hesitancy, at least in the last 20, 30 years, has been centered on MMR and a purported link with autism. MMR, super effective, as I mentioned before, for the measles, not so much for the mumps. HPV, another vaccine that's refused at really high rates. This is actually a really safe vaccine. There's no sort of serious side effects associated with this. It's very effective. They keep adding new indications for why to do this, most recently head and neck cancers. And so this is a vaccine that's extremely important, not yet mandated for schools in our state, which I hope we can change at some point in the future. Flu vaccine. Just want to take a second on the flu vaccine, because this tends to be the most refused vaccine, certainly prior to COVID. Flu is the most refused vaccine. And so we have the shot. We also have flu mist, the nasal flu vaccine that you can give to 2 to 49-year-olds. And people sort of forget the history of this, but in pediatrics, maybe 10, 12 years ago, the flu mist was actually recommended as the preferential flu vaccine over the flu shot for kids because it performed better. Then there was a couple years, 5 years ago, where it stopped working for H1N1, only H1N1. It was working fine for the other strains, but it stopped working for that. Got pulled off the market for 2 years while they reformulated it. Has now been back on the market for several years and seems to be performing just fine. The flu vaccine gets reformulated, as I think many of you know, every year. They change some of those strains. It has H3N2, H1N1, and 2 strains of B. And this year, the A strains were new. The B strains remained from the prior year. And the flu vaccine sort of changes in its effectiveness every year. I think what's really important when you have discussions about flu vaccine with families and with patients is to recognize that the flu vaccine has 4 strains in it, and its effectiveness for each strain is different, even in a given year. And so whatever strain that it's not performing very well for often ends up being the strain that predominates in spread in society that year. That doesn't mean you shouldn't get the flu vaccine because it's not working well for H3N2 this year. You should still get it because it's going to protect you against 2 strains of B and the H1N1. And so people sort of forget to have that specific nuance to the conversation, which I think really speaks to some people, even in years where the flu vaccine isn't working really well. The antibodies to flu wane in 6 to 12 months. It wanes quicker in adults than it does in kids. In kids, we recommend getting that vaccine as early as possible, August if you can, before they start slamming each other in school. But in adults, there have been years where it has been recommended to hold off on giving the adult flu vaccine until a little bit later in the fall so that they have immunity that persists through flu season. COVID vaccine, this is the new one, right? So right now we have 3 different brands of the flu vaccine. They all go after the spike protein. The only one we're really using in children right now is Pfizer. I think it's only a matter of time until Moderna and maybe some others come into the market for kids. We're going down to 5 years old now, as we talked about earlier today. And now we're boosting people. These tend to work really, really well at preventing disease, particularly preventing severe disease and death. But as variants come out, I think the efficacy data is going to evolve. And the side effects, I think, you know, we learned about this, right? A lot of people are getting sort of flu-like symptoms, headaches. I was really sore in my arm. And we talked about the really rare myocarditis that tends to happen in teenage boys, transient, usually pretty mild, although, you know, we're admitting them to the hospital when it happens. They tend to get over it pretty quick. And it seems to be nowhere near as significant as the cardiac disease that comes from COVID disease. So just a second on herd immunity. You know, this diagram, I think, depicts it really well. The more people that are vaccinated, the less the disease is going to spread. And so it's really important to get high levels of vaccine uptake in order for it to do its public health job. When having these discussions with families, some of the vaccine hesitant families really get worked up by the number of diseases that we're vaccinating against compared to when they were children. You can flip that script a little bit if you want to talk about antigens. And so this sort of talks about the antigen counts that have changed over time. In the 60s, there were 5 diseases over 3,000 antigens, and today there's 16 diseases and under 200 antigens, although we have to add COVID, so really 17 diseases now. So I want to take a moment to talk about vaccine hesitancy and refusal, more than a moment, and start with the history. The history of vaccine hesitancy is really that as soon as people were making vaccines, there were people who were hesitant and opposed to vaccines. So as soon as that happened with Edward Jenner's smallpox vaccine in the, so 1796 is when he sort of conceived of the idea. And so we've been talking about vaccine hesitancy since the early 1800s, particularly in England with the Anti-Compulsory Vaccination League, and then in the United States with the Anti-Vaccination Society of America. The first case of the Supreme Court mandating vaccination happened in 1902 in the wake of a smallpox outbreak. And so there is a legal precedent for mandated vaccines, which obviously has become important recently. The Cutter incident happened in the 50s. This was a tragic incident where the one of the polio manufacturers didn't inactivate the vaccine, and it led to hundreds of people getting paralyzed and 10 people dying, and a slew of lawsuits coming after vaccine manufacturers. And then, as I mentioned before, with the DTP, which was the whole cellular version, which caused a lot of sort of significant side effects in kids, there were just lots of lawsuits. And by 1984, there was only one company still manufacturing that vaccine, and we were really at risk of not having enough vaccine to maintain herd immunity. And so what happened was the government stepped in. And really there were a couple things that happened. The National Childhood Vaccine Injury Act in the mid-'80s formed. The vaccine information statements came out of that. The NVICP, so the National Vaccine Injury Compensation Program, came out of that, as well as VAERS. And the things that are important to understand about those is that the National Vaccine Injury Compensation Program is sort of like a small tax on every vaccine that goes into a pot. And then if somebody ends up having a vaccine-related complication or adverse event that is known to be related to vaccines, like some of the ones I had on the list earlier today, they get paid out based on that, which has protected the pharmaceutical companies from being sued directly, which allowed pharmaceutical companies to stay in the market and again, protected the public health. The autism community has tried time and time again to get on that list and has never been able to make that happen again because of a lack of evidence base. And then this is a voluntary reporting system subject to significant user bias, right? So for instance, if you believe that there are problems with vaccinations, I think you're much more likely to report what happened in the time after a vaccine. And what is that time, right? Could be months afterwards where people are reporting things and attributing it to the vaccine. There are motor vehicle incidents that are that are reported to VAERS. So it's problematic, but it's really important because this is how you do post-marketing surveillance. This is how you find things that are happening at really, really low rates that couldn't be found in studies, like sort of blood clots related to the COVID vaccine or myocarditis. So I'm going to spend the next few minutes taking you on a journey through the history, the modern history of vaccine hesitancy, which really started here with former Dr. Andrew Wakefield, who essentially falsified data to find a link between MMR and autism, which was ultimately retracted, and all the other co-authors sort of came clean on what happened there, and he lost his license to practice medicine. But things snowballed out of control from there. And so celebrities got involved, social media got involved, lots of different sort of action groups got involved, and vaccine hesitancy became a culture. There's a whole slew of celebrities, athletes, politicians who have gotten into the anti-vaccine advocacy space, led by Jenny McCarthy. And on the other side, there are a lot of famous folks and politicians and Elvis, for instance, who famously got the polio vaccine on the Ed Sullivan Show many years ago, which was attributed to a lot of increased confidence in the vaccine back then. That was also an era where pandemics led to people having more confidence in vaccinations. We are not in an era like that anymore. And then, you know, during COVID vaccination, there were lots of sort of famous people who were making it known that they were getting the vaccine, including me, not really famous. In 2015, the measles outbreak happened at Disneyland. And that was really sort of the beginning of maybe the tide turning from that sort of Andrew Wakefield-led vaccine hesitancy, which caused lots of headaches for family docs and pediatricians for many years. And then all of a sudden there's this measles outbreak, which was terrible, but did lead to some states changing some of their policies. So for instance, all states allow medical exemptions. This is exemptions to school, as they should. But for many years until the Disneyland outbreak, 48 states allowed some non-medical exemptions, whether they be religious or personal belief. Now, in the wake of that measles outbreak, there are 4 other states, California, Maine, New York, and Connecticut, in addition to West Virginia and Mississippi, who always did not allow non-medical exemptions, who've gotten rid of religious and philosophical exemptions. Delaware still allows religious exemptions, which again is something that if we really want to strengthen our public health vaccine uptake, that is definitely one way to improve it. And this is just a map that shows you the sort of exemption situation, and the states in white are the ones who are not allowing non-medical exemptions. And again, that's just for school, right? People can still not vaccinate their kids, they just can't send them to public school. So from the perspective of social media, so at some point I got on Twitter and found my people. My people are the pediatricians that are sort of pro-vaccine, and so sort of want to give you some sort of a journey through the last few years from that perspective. So you can see here in 2018 to early 2019, again, in the wake of this measles issue, when California got rid of non-medical exemptions, doctors started selling medical exemptions. And famously, Bob Sears, the sort of writer of the book about the alternative vaccine schedule, lost his license to practice there because he was doing some shady things. Then the Russians got involved in using their sort of bots to amplify the vaccine debate in our country. It got political for the first time. You know, historically, the anti-vax community was really composed of upper middle class, well-educated, sort of granola folks, and which is why we saw a lot of it in like Seattle area, stuff like that. And that just changed, that got flipped, right? And so we started to see political action committees getting involved in midterms. The measles outbreak started to climb in late 2018 as we approached 2019. That's if you're focused in our country. If you're focused outside, like in Madagascar, it was just devastating. About 1,000 people died from measles at that time. The World Health Organization named anti-vax movements as one of the top 10 health threats in 2019. That was the first time in history that anti-vax sentiment became top 10 on World Health Organization's list. Social media organizations sort of were involved in it, in that there was a lot of misinformation going on, and then started to crack down on that, although I think maybe not enough. And then what you started seeing, even though measles was spreading, was that people were out on the streets protesting to make sure their kids could remain susceptible to measles in the middle of that outbreak. But in other places in the country, they were handling it in different ways. And so in New York City, they mandated measles vaccine, and they excluded kids during the outbreak who weren't vaccinated from school. And we got to the point where measles, which had been eradicated from endemic status in the United States, was like on the verge of becoming endemic in our country again. In UK, they lost their measles-free status during this time. We talked about the medical exemptions. And one thing that came out of this measles outbreak, it was very clear that like somewhere around 90+% of the kids who were getting infected during the measles outbreak were ones who were under or unvaccinated. And then COVID hit. And lots of bad things come from COVID, but if some good things came from COVID, the measles outbreak ended like in a day as soon as COVID started. So did flu spread by March of 2020. And as was alluded to earlier by Dr. Rattay, so did a lot of our preventative care. And so we saw a huge drop in well child care and immunizations across the country during the spring of 2020. And people, including Nemours, started coming up with innovative ways to deal with that, right? Like setting up tents outside and making safe spaces for people to come in. And ultimately, like at Nemours, we vaccinated more kids in 2020 than we had in any prior year. So we caught up nicely. So this sort of talks about how things changed from the sort of crunchy liberals to far-right crusaders becoming the anti-vax voice in our country, which was just really very different than what we were all used to. And then it became the sort of this combination of anti-vax and anti-mask, so sort of against all evidence-based public health measures, really in the guise of this freedom fight. And then Massachusetts did something that nobody's done before, which was mandate flu vaccine for school entry this past school year. Polio was eradicated in Africa. Nobody was talking about that one. And then we started vaccinating, as we talked about. I think Rick went through a really nice journey of the last 2 years, but in December of 2020, we started vaccinating adults. And then by, I can't see the top of the screen, but this was by the spring, we were vaccinating kids. And so then we started to get some interesting data. And you know, I could spend 2 hours talking about the data that has come out around COVID vaccine confidence and hesitancy around the world. There's rich body of literature at this point, but not a ton on children, and certainly not a ton on the impact on other vaccines. Most of it is on COVID vaccine itself. But so this was a study that came out just a little while ago in July, which showed that there was significant increase in vaccine hesitancy during the pandemic, but that has not impacted intent to vaccinate for routine childhood vaccines. I should have switched these slides, sorry. So sort of back on my journey in August, we started mandating vaccines, right? So now we start talking about mandating not just for school, but mandating for our jobs, which is not new for most of us, right? Like we have to get the flu vaccine at Nemours, hepatitis B for people who are unvaccinated. Mandating vaccines for organizations is nothing new. So sorry again, back to the literature. So this was a study that came out. I think I just put these in chronologically, so forgive me. So this is a study that came out in August, looking at, again, vaccine hesitancy overall, which showed that COVID vaccine acceptance decreased from 70 to below 50% in the 8 months since the pandemic started. And that's shocking, right? As I mentioned before, this is like the first pandemic where it didn't increase people's desire to want to get the vaccine, right? Polio, like people were lining up to get that vaccine, but for some reason, COVID vaccine is different. But this study showed that patients' intention to vaccinate against flu increased, which anecdotally, I was sort of feeling that, like everybody's saying yes to the flu vaccine, they're holding their nose for COVID. And then California was the first state to mandate the COVID vaccine for schools, so adding it to the school mandate list, which I think was wise. Kaiser family last month, sorry, 2 months ago, put out a survey really looking at hesitancy in that 5 to 11 population, right? Asking parents, what are they going to do? And they asked them in July, they asked them in September, they asked them in October, and look at this green group. The definitely not group keeps getting bigger and bigger. Why? I'm not sure. We will talk about it a little bit, but that's really concerning. And people, what are they concerned about? They're concerned about long-term effects of the COVID vaccine. I already told you, there is no precedent for concern for long-term serious side effects with vaccination. There's just not. And yet that's what 3/4 of parents are worried about that. They're worried about serious side effects. And again, there's serious side effects from vaccines are super rare, but they're worried about that. And less so than they are about COVID virus. They're worried about fertility. They're worried about mandates. They're worried about taking off from work. They're worried about trust. Cost of the vaccine. This is a vaccine that's subsidized by the government. They're worried about cost and transportation, right? So there's a lot of things between your patient's arm and the vaccine right now. And then finally, this is just to demonstrate just how social factors, demographics, gender, politics, income, education are impacting people's willingness to get the vaccine. And it's wild to me when you see Democrats here and Republicans here, because that's like the #1 factor right now. And like, how do we as a healthcare system get at that, right? Like that's, I am more comfortable talking about race than I am politics with my patients right now. And that's crazy statement to me. And then the 5 to 11 came out at the end of October. And so that was the journey. Now, I want to take a little bit of time now to get back to sort of like, now what are we going to do about this? And sorry, I haven't been monitoring questions or chat. So, Kate, let me know if there's anything that I should pause and answer as we go.
Dr. Miller, do you want me to do it that way, or do you want me to hold the questions until the end?
You know what? Let's hold it till the end. I'll just
okay.
keep rolling.
Sounds good.
Yeah, sounds good. Here we go. So in order to address vaccine hesitancy, I think it's important to understand that you're not dealing with like a monolith here, right? The patient in case #1 who was against all vaccines, period, is not the same as the patient who says no to the HPV vaccine and nothing else, right? And so it's really important to understand that your approach to these patients really, I think, has to be different depending on what type of patient you're talking about. Some people are just a little bit hesitant because they spend too much time on Facebook. Some people don't want the MMR because they're worried about autism, or don't want a vaccine because it might have fetal tissue in its derivation. Some people are concerned about the timing, like they're too much too soon, right? They don't want to do that to a 2-month-old or something like that. Or the total anti-vaxxers. And then there are specific controversies that occasionally come up that I think it's important to sort of understand so that you can address it. MMR and autism. There are now, I think, 20 or more huge studies, millions of children, and they have not found a link between those two things. So like, we feel really confident that that's not our issue there. Thimerosal, really effective and safe preservative that's now not in any of our vaccines except for the adult multi-dose flu vaccine. And it's totally safe. There was no concern. Thimerosal is not a dangerous form of mercury. There are dangerous forms of mercury. Thimerosal is not one of them. But because we were worried about vaccine hesitancy 25 years ago, thimerosal got pulled out of most of our vaccines, even though it's very effective. Guillain-Barré syndrome. There are some vaccines associated with Guillain-Barré syndrome over time. I believe like it was the 1978 H1N1 flu vaccine had a stronger association with Guillain-Barré. Most years there's really no association with Guillain-Barré and flu vaccine. Flu virus has a significant association with Guillain-Barré, far more than the vaccine. So it's definitely recommended to vaccinate people unless they have a personal history of Guillain-Barré related to a vaccine. no evidence that autoimmunity is related to vaccines. I mentioned fetal tissue. It is true that there is a culture of fetal embryo fibroblast cells from the 60s that is still in perpetuity, like it's maintained to today. It's the same cell culture that is growing now. And that is used to make a couple of our vaccines. The Vatican put out a statement, said it's fine, use those vaccines, but you will occasionally have patients concerned about that. People bring up HPV. Maybe they won't anymore. Maybe they'll focus on COVID or something else. But for a while, they just brought up HPV because it was sort of the new kid on the block and they were worried about it. There's really no issues with that one. People will bring up aluminum. Aluminum is an adjuvant, which means that it has the ability to increase your antibody response, your immune response to a vaccine. The amount of aluminum in all the vaccines that a child gets in their entire lifetime is like less than a serving of broccoli. And so it's really not a significant concern. There's no safety issues there. And then too many too soon. In fact, it's quite the opposite. The vaccine schedule as recommended has been studied to be the most effective and safest schedule. So we do want to do it at that age. So a little bit on ethics. I wouldn't be a good ethicist if I didn't at least touch on this. When we think about autonomy, beneficence, do no harm, and justice, it's important to think about this vaccine decision in that context, right? So people bring up autonomy. That's what you're hearing all about, right? Freedom. But what is the freedom about? Freedom to get the vaccine or freedom to be free from a society where you might get polio, right? Like those are two sides of freedom. I would argue that freedom from polio is far more important than freedom from a needle stick with a polio vaccine in it. So let's not get into the freedom argument. But autonomy, parents should have the right to choose what is done to their kids within reason. And in our country, in absence of a pandemic, our courts have not supported forcing parents to vaccinate children. It's just, we haven't gotten to that point in our society. We can do things like mandated for schools, but we haven't been able to sort of force it in the absence of a pandemic. Autonomy also comes up between adolescents and parents, often with regard to the HPV vaccine, now with regard to COVID sometimes too. Beneficence, so who are we talking about when we talk about best interest? We talk about your patient, we're talking about society, we're talking about your waiting room. How about who's at risk of harm, right? Is it the immunodeficient patient down the street or in the classroom, or is it your patient whose parents are worried about freedom? And then justice. I will argue that there is a protection of the vulnerable status person that's important in this, as well as distribution of resources. COVID vaccine really brought that up, right? So never before in my career, other than in the context of the H1N1 vaccine, was there really this sort of distribution of resources issue with vaccinations. It was wild. And thank you, Dr. Han, for working through that. So under immunized children, a vulnerable population. It is my theory, hypothesis, that kids who are under immunized really are a vulnerable population for three reasons. One, their caregivers, their parents usually are making inadvisable medical decisions for them, at least regarding immunizations, sometimes with regard to other things too, like masks. This child now has a relative immunodeficiency compared to their peers. They are at risk for measles, for meningitis, for cancer at higher rates than their peers. And their only protection is herd immunity. And in our society, this really has led to a decrease in access to good, adequate medical care, in large part because pediatricians are dismissing these families from their practices, which leads to them clustering in practices that either refuse to dismiss them or sort of these vaccine-friendly pediatricians like Dr. Sears that are really anti-vaxxers. Or these families lose trust in modern medicine and seek alternatives because they're getting kicked out of practices for this vaccine decision. And so what can you do when you have people that are refusing vaccines? So in the pediatric world, we have this refusal to vaccinate form. I don't really use that. I just document in my note, like, I tried, I failed. Are there legal interventions? We talked about that there has been sort of precedent in the context of an outbreak to mandate vaccines, but in the absence of an outbreak, there really has not been a precedent for mandating vaccines, and there really is a legal right to refuse them. And so some people have chosen to dismiss these families from their practices. And what you see, and here's a study that was done just a few years ago, was that about half of people were using this refusal to vaccinate form. 1 out of every 5 pediatricians fires these families from their practices. Again, like I said, sort of eroding that trust situation. But very few family practitioners are doing that. And just to talk really quickly about the pros and cons of doing that. So if you're going to fire a family from your practice, the benefit of that is you have less unvaccinated people in your waiting room, right? You're sort of protecting your waiting room. You're sort of laying down the law on vaccines. And I think some docs don't feel comfortable working with families where they have those types of differences or a loss of trust. I think the downside, and if you can't tell where I land on this one, like, I don't think we should be doing that, because it forces them to my waiting room. It means that their access to good healthcare becomes more and more limited. It misses the opportunity for continued education. I will tell you that if I fired these patients the first time I met them, I wouldn't get them vaccinated, but I keep them around, and like, a lot of them change their mind. And then we keep a registry in my practice of all the patients who are unvaccinated for something, right? So it's like measles. When the measles outbreak happened, we called all those families and said, has the risk-benefit ratio changed for you? There's a measles outbreak. And a small handful of those families came in and got vaccinated. And there's no evidence that threatening firing them gets them vaccinated, although maybe there's some truth to that. All right, so what do I do? If I know a family is an anti-vax family, like from the outset, like they come in with their sort of pin on, I let them know at the beginning that vaccines are important to me, but that's not all that's important to me, and that I really care about their kid, and that I want to work with them, and that we'll have a lot more that we're allied on than things that we're not allied on. And I usually spend my first hour with them, my first visit with them, whatever it is, not talking about vaccines. Now, if we're talking about COVID and flu and things where it's seasonal and the urgency matters, it's a different conversation. But for these total anti-vaxxers, like case number 1, I usually don't go after them the first time I talk to them. I get them to love me, and then I come after them. And I think that's really important, right? Because the trust is a huge part of this. I listen, I talk about risks and benefits. I try to sort of correct their mythology. I share some real life stories. I tell them about my patient who died from flu. And I work with them. I have some families that'll vaccinate, but only, like, I had one family that made me give the vaccines with my own hands. I had another family that only wants to do a couple, and wants to torture their child for a while. And if they make me do it, as long as it's going to get the vaccine into them, I'm going to do it. And I don't give up. And I'm surprised often when families come back and they're like, we're finally ready to do it, doc. But those things don't always work. When you're trying to get the COVID vaccine into somebody, you need to try to get it done as soon as possible, right? The flu, like, if you don't get the flu into the kid like tomorrow, they're not going to be appropriately immune as flu starts to peak, as it looks like it's about to in the coming weeks, right? And so I think there's a few different things that you can do. And these are the evidence-based techniques out there. So one is the presumptive approach. Zuri is due for her vaccine today, or we are doing the HPV vaccine today, or like, today we're doing the COVID, right? Rather than asking, that works. Motivational interviewing, so trying to do it in a way that's not paternalistic. So if somebody says no, then trying to figure out where they're at. Are you worried about COVID? No. Okay. What are you worried about? And so sort of try to get to where they're at, meet them where they're at, and then sort of eventually bring them along to where you think you can get them. And then persistence, like, do not give up. Persistence during a single visit and persistence over time. So just because they said no when you first asked at the beginning of your visit doesn't mean they're going to say no by the end. So don't give up on these patients. And then upstream approaches. And this is where I think we can make a lot of the difference. So for instance, eliminating non-medical exemptions, adding vaccines to the public school mandate. Every single vaccine that's mandated for public schools has over 90% uptake, period. That's the difference between HPV, flu, and COVID and every other vaccine that's recommended for kids right now is the school mandate. What else can you do? So we've created a protocol for under-immunized patients in our practices. So like all of our practices sort of have a way that we're going to manage them. We keep a registry of them. They don't go to the waiting room when they're sick. This is even before the pandemic, although the pandemic made this really easy, right? Like everybody's masked now, and we're not really using our waiting rooms to the extent that we were before. But this is how we were handling these patients even before. They would get masked. We would go to the parking lot if we thought they had chicken pox or something like that. They have to come for well visits. They cannot come for walk-in visits. And then think about QI, right? Like even if you're in private practice, you can do quality improvement, find new ways to improve your vaccine uptake, right? Does your EMR have prompts? Can you do standing orders? Can you start vaccinating at sick visits and follow-up visits and not just at well visits? All right, so why don't I pause there? I have some slides on like the research we're doing, but I'd really like to be able to address questions because that's really the crux of my talk right there.
There are a few.
Okay.
The first one is not so much a question, but maybe you could give your thoughts on this comment that the person wrote. Polio has a significant death disability threat, and the vaccine offers significant protection efficacy. COVID doesn't have a similar profile and may explain the lack of the asking for the vaccine.
Yeah, you know, so there's some truth, like a disease that is absolutely devastating, like polio or Ebola, is going to drive people out to get vaccines in a much stronger way than some of these more silent diseases, or ones that are mild most of the time, the way that like flu or COVID is perceived. And so I totally get that. I don't agree with it, right? And so I think that's where we have to sort of meet our patients and help them understand just how devastating COVID is, right? A lot of this is people are more fearful of the vaccine than they are a disease that's killed 800,000 Americans. More kids have died from COVID since it started than like the last decade of flu. And so, you know, it really is severe, but just not for most people who get it. And I think that is, you're right, that is very different from polio.
All right, first question, how immunogenic was DTP and how many side effects were reported? Interested in how this compares with the number of side effects we see for the COVID vaccine, especially the second and third doses. And is reformulation of COVID vaccine to lessen side effects perhaps eventually possible?
So that's a great question. So DTP was very immunogenic. It's still pretty immunogenic, particularly for the D and the T, but it was very like over 90% efficacy for that one. And you would see side effects at fairly high rates, like high fevers was happening in third of kids, and which meant that you would see febrile seizures at a decent rate. You would see some of these things. So they were happening at high rates. You know, my perception is that the sort of flu-like side effects of the COVID vaccine aren't what people are most concerned about when I'm having these conversations with them, where sometimes that was the concern for people with the flu vaccine. Like I would ask them, I often get like, I feel so bad afterwards, why should I get it? Okay, right. But I'm not hearing that as people's concern for the COVID vaccine for the most part. But yes, you know, I think all the vaccine manufacturers are always looking for ways to make their vaccines more tolerable so that they can get it out there more, right? So I do think that has to be some of the research, particularly around mRNA vaccines, which we're having sort of this new experience with in humans over the last 2 years, really should be how do we optimize those vaccines, both for efficacy and side effect profile.
Next question, is the flu more refused than HPV for all ages or only certain pediatric populations?
So and it also depends where in the country you're talking about. So the flu vaccine in a normal year is, you see the most acceptance in the youngest age groups, and that sort of gets lower and lower as you get older. So adults have lower rates of flu vaccine uptake than children. Usually in children, it's over 50%, and often in infants, it's over 60%. HPV vaccine nationally now, the HEDIS metric, which is like completion by 13 years old, well over 50%. I believe it's pushing 60% now, and that's completion at 13 years old. So it's actually fairly similar. I think it's less so, again, for HPV. The older you get, the less uptake you get there. So maybe I misspoke. Again, the ones that are not mandated all are low like that. You see them hovering plus or minus 50, 60%.
Do you think the parental concern about long-term COVID side effects could be fueled by the long COVID discussion?
That's a great question. Maybe. I haven't, that hasn't come up for me. I don't think people are linking long haul COVID and potential long-term side effects of COVID vaccine. I think they're just worried that there's something that we don't know yet because this is new, right? And that has to be coupled with this feeling that it's worse if I choose it for my child than if they get it on their own. If you know what I'm saying, right? It's this commission-omission bias we talk about in ethics, is the idea that if my kid contracted COVID, that's preferable if they get the same bad outcome, but they got it from COVID rather than from a vaccine that I chose for them. That's worse if I chose it for them, right, somehow. So even though the COVID vaccine is nowhere near as dangerous as the COVID virus, parents don't want to be the one to choose the thing that could cause something bad for their child. And so we have to also get over that hump too, which is problematic.
Do you know offhand how many children have died due to COVID-19?
It's around 600. I don't know the exact number right now. Right. But the worst flu year in the last couple decades was the year before COVID. And it was like almost 200 kids died in that year in our country from the flu. So we're talking about 600 in under 2 years.
How would you address COVID vaccine hesitancy in those who see vaccinated individuals getting infected with the virus?
Say it one more time, I'm sorry.
So the question is, how would you address COVID vaccine hesitancy in those who see vaccinated individuals getting infected with the virus? So like breakthrough infections.
Right, sure. So I try to tie it to the flu vaccine or other vaccines. None of them are 100% effective. We do not have a vaccine that's 100% effective. Although the Pfizer study of the 12 to 15-year-olds was 100%. But we don't have a vaccine that's truly 100% effective. And so we always see breakthrough disease of all diseases. The COVID vaccine absolutely gives you a decreased chance of getting COVID, definitely. But even more importantly, it gives you a decreased chance of getting really sick from COVID or dying from COVID. And if you have a decreased chance of getting COVID, you also have a decreased chance of spreading COVID, right? And so I try to talk about all those things. And I validate what parents say, right? Like they don't want to hear somebody lying to them, right? And so if a parent says to me, well, they can still get COVID, I validate that right away. You are absolutely right. They can still get COVID, but so much less likely after the vaccine than if you didn't give them the vaccine. And they're like, really? I thought it was just protective against hospitalization and death. That's a myth that really smart people are perpetrating right now. Like some of my best friends still seem to think that, despite how much I tell them. You are less likely to get the virus from after the vaccine, definitely less likely. But you can still get it. It's not 100%. The best studies showed like 94%, I think.
So here's kind of a two-pronged question. Is there a maximum amount of vaccine a child can receive in one visit? And then the second question is, one issue parents also raise is the number of shots. Given your thoughts on the hexavalent vaccine for infants, do you think it will change things?
Okay, so we actually went through the process of having to look this up. in the context of COVID, because there's just, and flu season, right? There's just so many vaccines for some of these kids. Like if you come in on your birthday when you're 1 or you're 4, like you're up against it. So there is no maximum amount of vaccines that a patient can receive in one visit. You need to have a certain amount of distance. And so, you can use arms and legs, and you can get multiple limbs involved to get as many as you can. And on occasion, we find ourselves giving 5 or 6 vaccines to a kid. So yeah, it happens. What was the second part of the question, Kate?
One issue that parents raise is the number of shots. So
Right.
Thoughts on the hexavalent vaccines. Do you think it'll change things?
Yeah, so, it's funny because they will harp on the number of shots, but not the number of diseases, right? So like you have a combination vaccine like the DTP or the Pentacell, that's the DTP polio Hib. They don't seem as worried about that usually. We certainly have some anti-vax, vaccine hesitant people that want the components separated, but that's a separate thing. The hexavalent one, very exciting. I do think that'll help. Absolutely. For the majority of families, I think that will help.
Next person, curious to know how you handle parents or patients who refuse vaccines based on religious beliefs. I have found it very difficult to get them to come over to the vaccination point of view because they are so set in these beliefs. This has been more of a problem during COVID for adults.
Yeah, so I personally try not to handle religious beliefs differently than I would anybody else who holds some sort of belief that is against vaccinations, right? Like I don't care as much about like where it comes from, because the truth is there's only one organized religion that expressly forbids vaccines, right? That's sort of Scientology, right? Christian Science. No other organized religion is expressly forbidding them. So wherever that's coming from, it's really a personally held belief for most people. And I think that's an opportunity for motivational interviewing. That's your chance to sort of just figure out, like, what do they care about? Because they care so much about their health usually, or their kids' health, or their grandparent, or there's somebody that they care about. And then once you kind of sort of figure that out, I think then you can start to have this discussion about, and I really try to focus on COVID, not the vaccine, but the virus, right? Like why should we really care about this? And then what do we do about it, right? And sometimes what do we do about it ends up being the vaccine, but maybe there's other things that they need to sort of start doing first. So for me, that's how I do it. Some people, it might be worth getting their religious leaders involved, again, because like for the most part, the organized religions aren't telling people to not vaccinate. Some are. And so it's important to understand that before you guide them that way. That's hard.
A couple of questions asking if your slides are going to be available.
Sure.
Okay, done. What is the best way to counter misinformation on vaccine side effects on social media?
So social media is an interesting beast. I think it's really important for us to be sharing stories where appropriate, right, with HIPAA confidentiality, right, maybe your own kids and stuff like that, about the other side of things, right? Like the things that hit the news, the things that hit social media are often when bad things do happen in relation to vaccines or associated with vaccines, or coming from non-credible sources. And so I think it's like everybody who's here, if you're a pro-vaccine, if you're an advocate, like we need your voice, right? The more of that voice is out there, the more I think mainstream that becomes. I think it's important to hear that. So if your kid gets a vaccine and has no side effects, like put that out there, right? Like that's what people need to hear, or that it was mild. So I think that has to be part of it. I think we need some really strong voices out there. There's a few, but like I can name the anti-vax celebrities. Like I had to look up the pro-vax celebrities. I know Dr. Paul Offit's a very vocal pediatrician out there, but how many, Dr. Fauci, right? Like how many can you really name? We need more.
Given this situation, how can one size fit all?
So one cannot, and thank you for saying that. I think I had one slide talking about that. You cannot. So for instance, if you spend 15 minutes, if you're a pediatrician and you spend 15 minutes with every patient all day long and you say 25, 30 patients in a day, you have to sort of figure where you're going to spend your energy, right? If you have an anti-vax family who's one of those like 1-2% people who just is against all vaccines, I would argue that you probably shouldn't be spending too much time with them every single time they come, because you're not going to get a lot of bang for the buck. And you really should be going for those people who are like in the middle, right, where you really can make an impact. So I think, you know, in the long term, I'm working with those total anti-vax families. But like, where am I going to devote my energy? I think you have to be thoughtful about where you're going to do that. And it's those people in the middle, where that's where the action's at. And you look at those studies, there's a lot of these people in the middle. And they're just not they're not internally motivated to get out there. And like right now, these mass vaccination events are great, but you're not going to get any of the hesitant people at those mass vaccination events, right? This is where the family practitioners and the pediatricians and the internists and the specialists, this is our battlefield right now. Like, we have to be giving these vaccines in our normal operations in order to get the hesitant people vaccinated, because that's when they're going to do it. The studies show they trust their provider. The slides I was going to show you were some studies now in Delaware. The people who don't want the vaccines, there's racial disparities, there's ethnic disparities, and they all say they trust their provider. They do. And they're not going to come out and get it on their own. So when you see them, you have to get it into their arm.
All right. Thank you, Dr. Miller.